I'm back. Are you sick of me yet? I've got another live today. Gosh, this beard is really looking bad. I've got another live today with my friend from Australia. So let's get him on here. And you guys can all see. Where are you? DFY Dental. Fadi's on here. Let me just connect him. Fadi, can you request to be part of this? There he is. Here we go.
There you go.
Connection. Hey, how you
Can
doing?
you? Good. How are you?
Oh, Rob Ritter's on. Hey, Rob Ritter. So many friends joining. So what time is it in Australia?
It's 8 a.m. Nice and early, fresh.
On Wednesday, right?
On Wednesday, yeah.
Wednesday, yeah, okay. You got a whole nother day on me.
Yep, just started. Good way to start, Kyle. Good way to start.
Yeah, thank you. So, why don't you quickly introduce yourself, say where you're from and what you do so that my followers that don't know you can know who you are.
Well, hello everyone. I'm from Sydney, Australia. I've graduated from Sydney University. I've been in private practice now for nearly 29 years.
Wow.
So I'm getting on. I've got a lot of interest in multidisciplinary treatment. Started off doing a lot of orthodontics, then moved into implants, and probably the last 15 years, a lot of cosmetic, aesthetic work. But I also do a lot of immediate loading and
Hmm.
sort of full mouth rehab. So I tend to do a fair bit of dentistry. I
Yeah,
love it. I live it, breathe it. So it's just one of those things. I'm almost in my 30th year, and I feel like I just graduated, and I feel like I don't know much, which is a good way to go.
yeah, for sure. That's um that's quite a lot because I know when your son came out to visit me in LA, he was telling me that you do like full ortho and
Mm.
I mean to do so much, that's really, really awesome and comprehensive.
Yeah, I mean, over the last 28, 29 years, I've had blocks where I've picked an interest, and I guess one of my mentors, who's an amazing dentist, actually, is by the name of Ian Walters. We all have these great mentors.
Yeah,
And one of the things I saw him do was a lot of multidisciplinary work. But one of the first things he said you need to learn, and it always stuck with me, is if you really understand orthodontics. So you either learn orthodontics really well or have a best friend that's an orthodontist,
right.
because it's one of those anchors in dentistry that no matter what sort of treatment, and we're seeing it a lot now in a lot of as you know, in aesthetic work, pre-aesthetic alignment makes your case look so much better, so much easier, so much
For
more
sure.
conservative. And now you're doing a lot of implants, having that flexibility, that ability to control, moving gingival margins. All these things now, for me, it's like, wow, 30 years of doing this stuff, it's not a big surprise. It's not a paradigm shift in how I treat my cases. I just assumed that's what you have to do.
Yeah,
So that was probably one of the best pieces of advice, because everything else just organically grew into it. You master your orthodontics, or you work with someone that's really well disciplined, then your aesthetic cases are going to be great. You start doing implants, you can create the space. There's no rush. Your gingival margins can be tidied up. You're not having to do, limiting how much gingival surgery you have to do if it's
yeah.
unnecessary. So it really is
I
incredible. And I get a
I
lot of young
think
patients ask me,
I think ortho is something that's kind of underused as well. I think
oh,
most people are
it's
using
unbelievable.
ortho for let's straighten my teeth.
Yeah,
And especially you, since you do ortho and you do kind of perio pros stuff as well, I
yeah,
think
soft tissue.
when I was in dental school, I thought ortho was straightening teeth, right? That was basically it. And then when I went to my residency and saw in Brazil what they were using it for, it totally changed my mind. And like you're saying, moving it for aesthetics before you do restorative, or like what we were doing a lot in my residency was, because it was based around implants, was, let's say we were placing implants on the bottom in a edentulous area that had been gone for a long time, and the upper teeth had super erupted. We were doing stuff where we were just like placing a few tads and putting rubber bands around the tads and intruding. And like in a few months, you had a perfect occlusal plane in order, and you know, we would place the implants at the beginning of the treatment and then intrude while everything was integrating. And by the time integration happened, you know, we were ready to restore. And I think the same thing is happening right now, being underutilized in the aesthetic zone with implants. As far as like, you see people do it a lot on stage, but you know, you have a tooth that is broken off of the gum line, unrestorable, and the gingival margin is too high for the implant. So what some people may do is extract the tooth, try to do kind of vertical, horizontal ridge augmentation. Hey, Nas is here. Hey, Nas. Hey, buddy. But I think when you can super erupt that, you can save on grafting. Then you can do immediate placement. It becomes, wow, we've got a lot of good friends joining. Friends from Brazil, from all over the place.
Yeah, that's some very recognizable names there.
Yeah.
So, I mean, you could even have an attempt at restoring that tooth. That's the other thing. I mean,
it's true.
You know, you can create a ferrule effect. You know, you get 5 years out of that. I think there's nothing wrong with that, you know.
Yeah,
I mean, 5 years in dentistry is a long time in the aesthetic zone. You know, there's techniques that change, there's slight modifications.
Especially in implant dentistry,
so if you can get that, and like I said, there's a lot of those things that are underutilized in the aesthetic space and allowing you to be conservative in your, especially in full arch case, particularly veneers. Everybody's prepping like crazy, you know, and you're trying to be as conservative. You look at all the beautiful cases, I guarantee you, and you know, we know a lot of these amazing clinicians in our group. Most of their beautiful cases have pre-ortho. They all have some level of orthodontics, and as soon as you do that, it totally changes the dynamics of the case. Everything's lined up. You can be conservative in your preparations. The thicknesses of the ceramic become consistent. The substrates are pretty much all aligned. You're not fighting another, you know, another variable because of thickness, and you know, you just and it's not difficult. I mean, you have aligners. You've got fixed. You've got great orthos out there. There's just that lack of communication at the moment. The orthos sometimes are not talking to the restorative guys, so they're just straightening teeth. Nobody's talking about, okay, but this case might be a veneer case after, so there might be slight changes in where I want to finish. These are important things, and you do that, and all of a sudden these cases are totally simplified.
Yeah, it's the same. I think the same problem that we have in all specialties is that the specialists aren't talking with the restorative doctors aren't talking with the specialists. It's kind of coming from both ways, you know, because most of us general dentists we don't know about ortho, right? Like I don't know a ton about ortho. So like, what do I have to contribute, I think is what most people think, when really you need to communicate what you do know, saying, hey, this is where I'm planning on going. Can you give me that? Because this is the end goal. And it kind of all goes back to this DSD concept. I remember when I first saw Christian speak, and he was talking about, if you have fixed ortho or aligners or anything, you want to see the patient before everything's removed. And you want to verify where the teeth are going to go and see if you have space, because if you're 90% there, that's good, but it can be 2 months of change, and then you can make it so that you don't have to prep that tooth, you just have to put a margin, or you don't have to reduce as much. And I think when we can communicate that with our specialists, and for you, because it's in your own office or even in your own hands, we can ultimately get like you said, more predictable, less invasive, longer term results from this by doing something that's very predictable, like ortho.
Yeah, you look at all these cases that are sort of done with a really good team. I mean, you know, without a doubt, we've got so many great clinicians
we've
in the
got
group.
all the ones. Yeah.
We've got the bomb. And you look at all those beautiful cases where they've got their in-house ortho, and they're working so close. They're literally there at the prep. So,
right.
and just like when someone does their own orthodontics, and you look at that, those cases are unbelievable because everybody's communicating at the right time. They're in constant touch. You know, nothing better. I love doing. If I've got a complex ortho case, I tend to do a mock-up initially for motivation of the patient. But then as I get towards the end of my orthodontics is when I do a secondary mock-up or do a second smile design just to verify. And you just see how things fall into line. And like you said, sometimes you do that and you think, geez, if I do another couple of more months of just getting the lateral incisor distances right. So if I'm creating space between two areas, or if you've got peg laterals that you want to just increase that space so that you can, you know, create a nice restorative size for the lateral
ratio.
You say, okay, well, I did one side, the other side didn't move as much. You can move it a little bit further, and you can just do those things, and then all of a sudden your case is just phenomenal because you can never get that back. You could, no matter how good a ceramicist you are, you can't cheat a distance. You can create line angles, you can, you know, do all these little ceramic tricks, but it's never the same as having the space, having the alignment, having the gingival correction. You know, it just makes your cases so much better. And again, it's the patience. You need to have patience because a lot of, and I know you teach a lot of young dentists, the thing they lack sometimes is patience because they have a case, they want to get in there.
I lacked it too as a young dentist too.
Right.
Yeah.
You're preaching to the most impatient young dentist that ever lived. You know, I slept with my handpiece in my hand. So
hey, Simon's here too, and Dr. Lindstrom. Hey guys,
So you could imagine, you know, you get a case, you're excited, patient's all ready to go, and you just want to start prepping. You need to be patient because once you get those first few cases under your belt that you've orthodontically aligned, and you compare it to the ones you haven't. You will never turn back, and then that patient just comes. And that's something you need to relate to the patient as well, because patients come in expecting no ortho. I've come here because I don't want to straighten my teeth. I want you to just give me veneers. I said, okay. I lose a lot of veneer cases because I have to have the orthodontic conversation because sometimes initially they think, well, he doesn't really know how to do veneers because he wants to straighten my teeth first. So that's the kind of response you get. They say, well,
that's an interesting perspective.
Because how come the dentist down the road, he said he can do veneers straight away for me? I said, well, he must have more degrees than I do because I do stand on that moral point. If someone really, really wants to have their teeth prepped and they've got severe crowding, I mean, I'd do it in the end. I'd rather I do it than someone else, but we go through a lot of paperwork and a lot of consents. Because I guarantee you, you know, a lateral incisor will devitalize in 12 to 18 months when you've got significant overlap, but they want you to prep those teeth. So these are the conversations.
We had a case that actually Christian and JJ had sent us, a friend of theirs who was in LA. And he had gone to kind of all the, let's say, the kind of famous dentists in LA, right? And he wanted to get
only famous dentist in LA.
he wanted to get his teeth fixed, and he had crowding, okay? And everyone said, you know, yeah, I can do it, but you know, he had kind of a crossbite on the lower, pretty severe crowding. And so what we did is we did the DSD protocol where we did a mock-up in his mouth. And he said, like, yes, that's it. That's what I want to do. And we said, okay, in order to do that, you know, it's going to be 14 months of ortho or whatever. And it was interesting that he came in being absolutely no ortho. And we ended up doing ortho, and it turned into just a bonding case. He got to the end of ortho and said, you know, really just this little thing bothers me and that thing. Okay,
And this is an excellent point. This is a conversation I have. So a lot of these cases that do come in exactly like that. And my first port of call is you definitely need ortho. And
Yeah.
then as the ortho progresses, another really good conversation is if you're seeing the ortho flourish really well. And one of the conversations I always have is I say, let's try and do the best ortho we can and let's reassess. Because you find a good 50% of cases say, oh my God, this ortho looks amazing. I actually like my teeth now.
Yeah,
And
I
this
know.
is great.
Yeah.
And for me, it's not about prepping. If I could do an ortho case with minimal bonding and let that go, you got to understand these patients are like 20, 30, 35 years old. You got to prep them now. You got to prep them in 10 years. You know,
Right.
by 20 years, there's not going to be any teeth left. So if you can create a situation where aesthetically they're happy and they actually understand, because they didn't understand that they could get to this aesthetic point with orthodontics and bonding, because in their mind, you know, they're on Insta and they've done their research, and they
Right.
see the only way to achieve an aesthetic smile is if I stick porcelain or veneer my teeth.
Yeah.
But once you make them understand, you know, the dynamics of a smile and how orthodontics can do that, and then you can add some finishing touches, it totally changes things. And like you said, we've had so many cases where they come to us and they're almost a little bit embarrassed. They say, well, I don't know, I'm not sure if I actually need the veneers. I said, you actually don't.
Yeah.
Because they sort of feel obliged sometimes because they're so happy with their teeth. And
But
this
you
is
know,
something that we have all the time. That's great.
from a patient, what should I say? From a practice management standpoint, I find that those cases refer the most patients to.
Oh, they go crazy with this stuff. It was like a miracle.
Yeah. Yeah,
You know,
because
this is a
I'm thinking
miracle.
of a case, where a patient came in, he wanted veneers. He didn't want crown lengthening, but
Yeah,
really he needed crown lengthening, which was what the big problem was. His teeth were fine.
yeah.
And so he came in, you know, the treatment plan that he had all the money. The money didn't matter for him. He really wanted veneers, which was a, you know, big treatment plan. We would have made a lot more money.
Yeah,
What I did was just the maxilla crown lengthening, aesthetic crown lengthening, right? Afterwards, he said, you know what? I don't need to do the veneers.
yeah.
And, you know, so our pocketbook, of course, is saying like, why'd you do this, right? But what happens is I feel like you get paid back for that by referrals. Because this
10
guy
times, 10
referred
times over.
everybody. He like referred everybody. Because he had gone to a few other dentists and they had all said, yeah, veneers, you know, veneers.
Yeah, I mean, when I did my master's, one of the best papers that ever came out, and I know we've shared it on our common group, is the daughter test. There was a paper written called the daughter test. If
Mm-hmm.
you treat every patient, every treatment plan like that, it comes back to you. You
Yeah,
know, would you had veneers if it was you, if it was your brother that walked in? Would you?
right.
What treatment plan would you do? If you treatment
Yeah.
plan like your treatment plan for your family, not
Mm-hmm.
your brother-in-law, because sometimes those relationships aren't the best, but you know, but you treatment plan as your treatment plan for family, you will find that consistency will come back and you'll be rewarded 10 times over. Your treatment plan, everybody the same as though you would do it for yourself. And,
Yeah.
and that is the easiest way to do dentistry. Even if you're in the aesthetic space, even if people are coming in, you just got to basically stick to your principles on what you feel is the best treatment. And if you do that, you can sleep at night. You can do 30 years of dentistry
It's
and
so
really,
true.
you know, and really sort of have a clear conscience.
Yeah.
And having all these sort of these supporting specialties, whether you do it yourself or core group, really helps you do that.
For sure.
But a good point that you made, Kyle, is the DSD and the ability to mock up. And one of my favorite ways of convincing people to do ortho is where you do a pre-orthodontic mock-up. So with the planning center, in certain cases, like you said, and I've done quite a few crossbite cases where I've
Yeah.
mocked up for them post-orthodontic, not post-orthodontic plus restorative. They can actually
Yeah.
move the teeth
Right.
around
Move
and
the
show
actual
you
teeth. Yeah.
just the
Mm-hmm.
actual teeth. And that is a great way to sort of people that are sort of borderline that really need ortho, that are sort of
Mm-hmm.
adamant. You do that for them, and then they say, wow, so you think we can achieve this orthodontically? All of a sudden they realize, wow, what they perceive as a great smile doesn't necessarily have to be through prep teeth. And
Yeah.
once you get that over the line, so that's a powerful tool. All my
Yeah.
tough cases with orthodontics, I've just done the simulation. I've done a DSD for them orthodontically, and it's always got them over the line, and they've been great patients.
Yeah, technology, I think, has made minimally invasive treatment easier. I'm thinking of like when I was talking to Simon Shard a few weeks ago, we were talking about how he does a lot of these, I think it's called ABC, align, bleach. Wait, is it align,
Yeah,
bleach, and
yeah.
composite, right? Align,
Yeah,
bleach, and
yeah, they call
composite.
it, I mean, yeah, light dentistry. Lucan and is doing quite a lot of it. They call it light dentistry. Yeah,
Yeah.
there's all that combo. It's beautiful.
Because that, you know, Invisalign or aligners in general have really brought that along,
Yeah,
you know, and that was kind of like what my teeth were really. Because people, you know, I have a lot of patients saying, oh, I like your teeth, whatever, you know, like who did your veneers, right? And I say, I'm a align, bleach, and composite kind of guy. You
I
know,
mean,
I had some composites on my laterals that my dad did when I was 15,
yeah,
and I had ortho twice, basically, and I bleached.
yeah. And that moving forward, I think is going to be the core basis of aesthetic dentistry, you know, especially, you know, the times we're facing ahead now,
Right.
generally. So there's going to be a lot more of that, and we need to be able to master that phenomenally.
Yeah.
And there's some beautiful techniques. I've spoken to um, couple of colleagues in terms of, you know, the injectable techniques with the
Yeah.
alternate teeth. Now
Mm-hmm.
there's a new technique, and I'm sure you hear about it soon, where they were using guided injectable techniques where you're able to inject in layers. There's so many different things, you know,
Amazing.
just
Yeah.
mastering the composites. But like you said, that aligning, whitening, then the composite is just a
Yeah.
phenomenal sort of treatment plan, which can be used using the same files that you eventually might use in porcelain. So it's
Yeah.
almost a dress rehearsal. So, you know, you're doing these beautiful digital cases that are so consistent. So you're able to sort of show the patient, well, you know, if we did ceramic, or if you can afford ceramic, this is what I'm going to be using. But I can also
Right.
do the same in composite, the same
Yep.
file, the same shape, the same
Yep.
facially driven design. So it's not, you know, it's not the ugly sister by all means. It's
Right.
certainly, you know, it's certainly very similar, and it's a nice stepping stone, and there's not a huge transition when you get to the final. So
Yeah.
this is another way that I do a lot of this stuff at the moment, especially, you know, with the younger patients that want certain things. This is a really good stepping stone, so they don't feel like there's a huge disparagence between both treatment modalities. So that
Yeah.
works really
Yeah.
well.
And we've had that a lot too, to where we have younger kids, let's say, you know, 15 to 20, something like that. And especially in LA, they're in the industry and they have these
Yeah,
peg laterals, or they have these weird spaces. And, you know, they come in oftentimes asking for veneers. And, and so many times we've been able
you
to
cringe.
do with, yeah, you know, you see this beautiful enamel and it's perfect,
Oh,
right?
yeah,
And we've been able to just do something minimally invasive,
yeah.
and, you know, who knows? It may last them for 5 years, it may last them for 10 or 15 years, who knows? But it's ultimately going to be better to start later if we have to do it.
Everything,
Yeah.
everything that, I mean, the more you can push the life cycle of the prep tooth, the more you can delay,
Yeah.
the longer it's going to be. Now,
Yeah.
I guess the question is, that's great. We want to be conservative. We play that, but then you got to also understand there's going to be a period of time where the patient's going to be looking in the mirror at their teeth. So there's a balance between where you're going to give them some joy in smiling, as opposed to being, you know, the textbook clinician of being conservative. And that's tough, right? That's
Yeah.
really hard,
Yeah.
because you got to pick the balance. You got to satisfy the patient's aesthetic demands,
Yep.
but by not being too controlled by that. But at the
Right.
same time, you know, not jump in the deep end and think about, okay, I've got to redo this in 5, 10, 15 years.
Right.
Can I redo it? What are the risks? Is the
Yeah.
patient aware that it's another, you know, tens of thousands of dollars? It's another new car. So
Yeah.
sometimes they come in and they think it's lifetime, and you've probably had this, especially younger
Yep.
patients. You know, I'm going to get them done now. I'm done. I'll get my veneers and I'm done. I said, what do you mean you're done? You're done for 10 years. You know, you have to redo them. What do you mean? You know, it's, and that's another important thing. And as soon as you
Yeah.
have that conversation, Yeah, maybe we'll try ortho first.
Yeah, I think this happens with implant dentistry as well. And then, you do a lot of full
Yeah.
arch cases, and with full arch patients, I was
Oh,
talking, I forget who I was talking with this to this about was full arch patients oftentimes have struggled with their teeth their whole life.
yeah.
And so for them, this is like the final out, right?
Yeah.
And really kind of dentures are the final out, right? You don't have to brush your teeth anymore,
Yes. Put them in a
whatever. You're not
glass.
you're not going to get infections, right? I mean, like, done. But implants, you got to maintain them. And I think that's something that early in my career, I didn't realize as much. Let's say my first 5 years out was like,
Yeah.
implants are the best thing. I love implants. And I do love implants. But what I tell my patients is, I think implants are a great replacement for missing teeth. They're not a great replacement for teeth.
Mm.
So if you have a tooth and if you can keep it, like I always say, in my own mouth, I'll do 10 root canals before
Yeah.
I have an implant.
Yeah. Until you get a
I'll
root fracture.
do, yeah, I'll do, extrusion. I'll do whatever, anything to kind of keep that tooth.
Yeah. And that's how it should be. But getting back to full mouth rehabs, which I do a lot of, and my conversation at the beginning, because people do come in, it's exactly what you said. Is like, I've had years of dentistry. It's a
Right.
terminal dentition.
Yeah.
I've decided I'm gonna get this done because I'm gonna get restored and then I'm done. I said, well, you're not really done. Okay,
Yeah.
this is a different path we're taking. We're going to give you, certain treatment modality. We're going to give you, the ability to chew. But, after 5 years, 6 years, depending on the prosthetic, that has to be redone. And it's all hygiene dependent. You need maintenance like everything else, except you're coming in 6 monthly for your implant maintenance as opposed to your normal maintenance. And they're like, oh, so what do you mean I have to have another set? Of course. Okay, your implants, if they're done well and placed well and good tissue around there, they're going to be lasting quite a while.
Yeah.
But your
Right.
prosthetics might wear down.
Yeah.
But what do you mean? I'm spending all this money. I mean, isn't this going to last me forever? And this is the conversation you have, because they think, wow, this is the magic ticket. And the first sort of consultation is, especially in full mouth rehab, is letting them know, and my simple analogy, and it's a good one, is, just to try and give them an understanding for the prosthetics is, you're getting a Bentley here. You're going to get beautiful Bentley wheels with Bentley tires, but even Bentley tires wear down.
Right.
So you got to understand that. They said, oh, okay, that's fine. So they understand it. So because people
And if
come in
Bentley tires are anything like Porsche tires, they wear down faster than regular
that's
tires,
right. Yeah,
Than the
you can't
Chevy
even
tires.
drive.
Yeah.
Yeah, so they got to understand these concepts. So and there's risk factors. I mean, I do a lot of these full mouth rehabs, and I found with all my cases that were very successful are based on two things: very strict maintenance, but the ability for the prosthetic to be cleaned by the patient.
Mm-hmm.
I mean, I do a lot of all on 4, all on X, but I find all these cases where you're able to clean really well do increase the lifespan without a doubt. And I've seen some beautiful zirconia, gum fitted, Pontics, and all this stuff, but they're very difficult to clean.
Yeah.
And you do find, if you have a pros that can be cleaned, the longevity and the stability around implants, without a doubt, is increased. So this is one of the things that has to be stressed in, especially in full mouth rehabs.
That brings up a really good point. Are you doing any removable full mouth?
No,
Yeah.
at all, at all.
Same here.
Yeah, I stopped doing it 8 years ago after I did some work with a few colleagues where I saw how we were preparing the surgical beds, paying careful attention to the underlying surface of the prosthetic where there was no concavity. You're able to clean. Like once I saw that, I just stopped doing overdenture stuff completely.
I think there's a place for removable I think the problem that I saw, and let me know if it's same for you, is that the
Yeah.
complication rate is so high
Yeah.
and the maintenance is so high. And there's a study that I always reference in my lectures, and it's something like fixed implant cases had like a 11% complication rate, right? And
Yeah.
removable was like 79% or something
Yeah.
like this. It was
Yeah.
wild.
And out of the 11%, you know, provided you're following all the, out of the 11% in fixed, it's usually prosthetic.
Screw
Chipped
loosening.
teeth,
Yeah.
screw loosening,
Yeah.
which it's not the end of the world.
Right.
I mean, if you, you know, for me, it's those things are nothing. I mean, they happen. You know, you get better and better. You start, you know, sometimes it's components, sometimes it's occlusion. There's certain things, sometimes passive fit, and we're just getting better and better at, you know, all these. My big deal is whenever I do these cases, I do try and get within the 24 to 48 hours a fixed milled titanium bar to be able to splint the implants. For me, that's a big deal. By being able to do that, we used to do floating bars and so forth. Now we get a milled titanium bar to brace all the implants. And I found that is a big, big deal. I'm not a fan of temporary PMMA for 3 months, then going to a Zirc. I try and get that bar in there, whether I do a wrap acrylic, whether I wrap PMMA around it. But I do find, you know, stabilizing the implants, beautiful soft tissue around there, is the key. And we do have high success rates with that. But again, there's a whole protocol.
So you're oftentimes not loading on that day. You're doing it 48, 72 hours
it's
later.
always 48 hours because by the time I'm able to mill and get the final process, so they usually, if I do the surgery on a Monday, they have nothing on the Tuesday and get issued Wednesday morning.
Oh,
you know,
great.
This whole mindset of they have to leave with teeth, I think it's just something that someone created, you know, same
marketing.
It's a marketing thing. And people come in and you tell them, and there's a reason why I need a day and a half, because I'm milling a titanium bar for you that's going to hold everything perfectly. And there's no risks whatsoever immediately. So, you know, we've done probably nearly 500 arches so far.
Amazing.
And we've exceptionally high success rates. It's a lot. You know, you're talking, you know, 4 to 5 implants per arch, constantly restored. And like I said, our biggest issue, and these are things we're working through, is, you know, chipped teeth, a chipped tooth, if we're using, you know, sort of resin teeth, we've had less with PMMA. But they're things that I don't see them as major issues. And there is always that 5 to 10% of males that will, you know, will break, you know, their bite capability is more than the material itself. They're not going to break the bar, but they will break that. And that's already in our paperwork in terms of, you know, we tell them there is that risk. And if that's the case, they're the ones that have to go to a zirconia at some point. So these are things that, you know, the more you do, the more patterns you see in terms of, you know, what are the risk factors. You can discuss that with patients. We have quite a comprehensive you know, documentation, because once you do so many cases, you know what are the likely scenarios. And patients are fine. I mean, some patients choose to ignore it after you've gone through it and things happen, but, you know, it's easy to remind them. But the key is, the key is to be able to design a prosthetic that is highly cleansable and highly rigid at the time of surgery. That's our big thing. We find we get quite a high success rate with that. And I'm a big fan of that.
Are two questions that I had. One, you mentioned tissue, having good tissue. Are you tissue grafting at the time of placement oftentimes, or what's your take on that?
Rarely. Sometimes we do, but the way I do my prosthetic space, we often, you know, I do give myself you know, and there's two schools of thought here. I know a lot of guys are very anti the alveolectomy and so forth. I find I do need 16 to 17 millimeters of prosthetic space. Space makes the case. Now, I find whenever I do that, I'm able to reposition the keratinized tissue in a much better place, particularly on the upper. You literally
because you can use the lingual as
the palatal tissue. It's unbelievable. On the lower, you have to be very careful because there's hardly any.
Right.
Sometimes I will go back and do that. Now with free gingival grafts, I'm finding some of these cases where I've had, I wasn't showing as much finesse in at the time of suturing because you literally have one little crest, but I'm finding you go back and you do a free gingival graft on there. That's a great, easy procedure, especially
After
lower
the implants are
anteriors.
placed?
Yeah. Like could
I
be
see.
6 months, could be a year. Because
Okay.
sometimes you're generally fine, and then you come back, you take it off, you do especially in the anterior region on the lowers, you often find there's nothing there. It's quite an easy procedure. Free gingival graft, you can do that. So there's all those little techniques. But as soon as you sort of flatten your ridges, particularly on the upper, you can really surround that multi-unit with beautiful keratinized tissue.
Yeah.
Another thing that I do, a dear colleague of mine taught me, is when you sort of, if you've decided 3, 4, 5 years later you want to do, say, an upgrade for a prosthetic, or you're looking at a zirconia, he gets a beautiful diamond burr and just smooths the ridges and just creates this amazing flat space because you've got such an abundance of tissue, and you can do it just with a high-speed diamond. And then you just create this beautiful space. You look at it a week later, you take an impression, and it's incredible. And and then the ceramic sits on top, the zirconia. So there's all these things that you can manipulate the tissues with, especially if you've got such an abundance of keratinized tissue, which you've created by your alveolectomy.
Yeah. And what is your what implant systems do you use? Do you have one? Do you use multiple, or what?
80% of my cases, 90% of cases were Nobel. Between active and parallel, depending on the bone. So I sort of, when I do my pilot, obviously active, if you've got soft bone, I find I go to a parallel. I've tried some BLX cases as well with Straumann that worked really, really well. But most of the cases I've done are either active or Nobel active or parallel. And again, depending on that initial pilot drill, depending on the bone configuration. I love
if it's one of those ones that like just drops right in, right?
Yeah. So if you do that, you definitely would be looking something like a parallel.
Something that has a aggressive thread pattern.
Yeah. No, the opposite. If you've got really soft bone, you don't want an aggressive.
I see what you're saying. Okay,
you want the opposite. So you want
because
something
then you'll
that
cut
can
through the bone
condense.
too easily.
Yeah, that's right. You'll be just spinning. I've also used with those components, and I'm sure you've looked at it, is the Versa burrs, those osseo-densification burrs. That's another really underutilized tool, especially in those cases. So again, the more cases you do, there's no cookbook. This is the thing with immediate loading. You really got to, each pilot drill is its own animal. And you really got to get an understanding for the bone. It's all about getting stability. And if you don't have enough stability per implant, you really do need to add extra implants. If you want to immediately load, you can't kid yourself on 10, 20 units, 25 units. If you find you've done 4 implants and you don't have enough stability, you do have to think about adding more implants. It's just if you want to immediately load.
I've got a friend who's an oral surgeon out here, and he guarantees his patients that they'll be able to load. And the reason why he can is because he does zygomas too. So, I mean, he's got like the Hail Mary. If something else isn't going, you can figure it out.
Zygomas, So I do zygomas with my colleagues. So when I plan my cases, I know before I've started the case if it's a zygoma. So I do all my surgery except my zygomas. So I do it with him. And so when I do my consult and we've got our CBCT, when I work out my restorative space, so this is good for you young dentists. So we've worked out, I've looked at the smile line. Patient smiles, I need 15, 20 millimeters, say 17 millimeters of restorative space. I've worked it already from the incisal ledge. I've worked out if I go back from the ideal incisal ledge backwards, and then I find, I've only got 6 millimeters or 8 millimeters left of maxillary bone if I want that restorative space. I don't want a transition line. That's when you say, well, that's a zygoma. Or you draw the same line across the posterior, and you think, okay, I've got to take away 6 millimeters of bone to have the restorative space, and where am I? I'm halfway through the sinus.
Yeah.
Then that's a zygoma. So you find,
or you could go to an FP1 on certain cases on those, right?
You could do those, but I do find the zygoma option is a brilliant option. If it's done well, and if you've got someone that's quite proficient. And a lot of these patients that have, been denture wearers for 20 years, have no bone, they really have no option but a zygoma, in terms of getting that immediate loading. And zygomas, when they're done well, and there's many different techniques, it's a brilliant option for patients.
Yeah, I think it's going to be something that it's already been growing over the last, let's say, 3 years. I think it's become a lot more popular, but I think it's really going to explode with all of the failures of all on fours that were done incorrectly 5-10 years ago.
100%. Because that's your only, So when people ask me, what's the percentage of zygomas in your practice? So because I have access to an amazing zygoma surgeon, and we've got a protocol. So if I see a case that is a zygoma, I don't start thinking, oh, geez, how am I going to place this? Maybe if I stick an implant here, maybe I can do less of an alveolectomy. So I don't think like that. I think, well, that's a zygoma, great. And I find 30% of cases, I speak to my colleagues, they say, oh, I get a zygoma once a year. It's because it's like, if you don't have the ability to provide it, you don't see it. So I've seen a lot of surgeons stick implants in, but don't think about the restorative space. So by the time you've come in to put the fixed bridge in, you can see the transition line, and it's like, goes like this, But also, ideally, they should have been much higher. And if they were higher, the only way was a zygoma. So the implants are great. They've integrated. Everything looks good. But you don't have enough restorative space. So when you create the right amount, all of a sudden the patients can't talk, or they've got phonetic issues. There's vertical issues. So this is one of the biggest pitfalls in immediate loading or full arch. Is not being able to plan.
We have a question. What about cases with big resorption? Yeah, I think that's
this
really
is
the answer.
Zygoma. That's the answer. It's either zygomas in the posterior and some really small single implants in the anterior, or if it's a massive resorption, we use quad zygomas. Like that's the key. And there's many ways to do zygomas. The way that my colleague does it is he tends to graft the sinus area. So he creates a graft wall between the Schneiderian, between the sinus and the implant. He doesn't allow just the membrane to rest on the implant.
Oh, that's cool.
So, so he creates he uses Bios collagen, creates a beautiful wall so that the implant is housed within. There's a nice buffer, and he always finishes the access hole of the pros exactly the same way as I do a conventional all-on-4. So if you look at his pros post-surgery and my pros, you can't tell the difference. I've seen some of these zygomas where it's almost like a torus palatinus.
I've seen it. It's very lingual.
So that's important. Again, you have to have the right surgeon.
Good question here. If we place zygomas, and unfortunately there are lots of complications and low success rates, speaking about longevity, what is going to be the alternative? It's a really great point, because at that point, we have to build bone. We have to call Sausage Jovanovic or Ispan Urban and grow centimeters of bone.
And that's why it's important to pick the right zygoma technique. So, in all of those scenarios, often the complications aren't usually osseointegration. Usually, the issues you have is sometimes exposure of the thread in the buccal mucosa. So they're often your situations. And again, that's treatment planning depending on the anatomy of the sinus and so forth.
So you're saying, I'm asking these because lately we see that we went back and started using fully digitized, customized subperiosteal. Yeah, that's really cool, actually. I think
I've done a few cases. I've done a few cases with a colleague of mine where he's done. He's actually an amazing max fax. So he's got a system which works really well for, say, upper edentulous. So they're
Yeah.
using the same technology.
Yeah.
So he actually does guided facial reconstruction, does guided orthodontic surgery,
Yeah.
almost exactly you do your guided implants. He
Right.
does that all. So he's got his
Yeah.
osteotomy drills, takes it off, then prefabricated the actual setting where the Lafort fracture is and
Yeah.
so forth, and puts it in. So he's created a system where he does the same for a full arch, So he uses the same bracketing, the same screws. So that is definitely another excellent system that you will start to see now coming through.
Yeah, I think if we are at a point where like the patient has really big resorption, we've done zygomas have failed, then yeah, we got to start kind of grasping for straws. If it's
Yeah.
some
Or
periosteal
that could actually
implants,
be, well, that could actually also be a
yeah,
first option. So it doesn't necessarily have to be a post-zygoma. It just depends who's doing it. I've been lucky in that I've seen both sides of it. This is perfect for patients that are a bit more medically compromised,
yeah,
because we're not worried about integration. So this is the other important thing. So zygomas and so forth is an osseo-integration scenario. These subperiosteals are just screws into the jawbone. They're fixated. So there's no actual integration per se.
right.
So if you have really medically compromised patients that can obviously can have the
Can handle
GA,
this surgery,
can
yeah.
handle the surgery,
Mm-hmm.
but might have diabetes and so forth, where it's too risky for a zygoma, this is a perfect option because we're not relying on osseointegration. The subperiosteal fixture is just
Yeah,
screwed down like you would screw down a broken jaw.
yeah. So this is a good question. When you have to grow bone in a full arch case, how do you give a provisional restoration? How do you avoid pressure on the graft? The
You
answer is
can't.
the patient doesn't have teeth. And I think
Yeah,
when we're and we've had those cases before. I've done some cases with Sasha Jovanovic like that. When we have those cases, it's just, you
nothing.
know what? This is the option. The option is
Yeah,
you go without teeth and
yeah.
you drink through a straw for, 4 6 months.
And that's why the resurgence of the things like immediate loading, the
Yeah,
zygomas, these are because people, and I got tired of doing these cases over 12, 18 months, praying every night that these patients don't do something wrong, or you
yeah,
lose one implant, or one gets exposed, or they want to use an overdenture with soft lining because they need teeth. Like this
right.
was too much stress, and they were
Yeah.
paying a lot of money for these procedures that
Hmm.
were that were failing. And at the end of the day, if something failed, you have to retreat it.
Yeah.
So that's when this immediate loading came along. It's like,
Yeah.
wow.
It was to avoid all the grafting because,
Yeah,
let's be honest, or let's say sinus grafting has a 30% complication rate.
yeah,
30% complication rate is pretty high. Vertical ridge augmentation, probably even higher.
yeah,
In the average surgeon's hands, it's very high. You have a very small amount of people that can do predictable vertical ridge augmentation.
yeah, yeah,
Yeah.
100%. So if you can minimize the complication rate by changing your procedure, your surgical sort of procedure, then you're onto the right thing. But all these other things, yeah, they're terribly complicated.
Yeah, I think we have to be strong-willed with our patients. We know what works, and I think oftentimes we get talked into things, right? Because
Oh, we
we feel
get
bad
bullied.
for
We get
them,
bullied.
Yeah,
You get bullied into these things because, again, it's so and so down the road can do it. Why can't
right.
you do it?
Yeah.
They like to poke at the bear sometimes.
Right. Yeah, I
And
love
it's
the
not good.
expression from Fight Club. They say if you want to make an omelet, you got to break some eggs. And I think that's definitely true with our patients is that like if we were to break our ankle and we go to the surgeon and the surgeon says like you have to be off of your foot for 6 weeks. You can't walk for 6 weeks.
Yeah.
And we're
What
like,
are you going to say?
no way. Just come
Fine.
on. I'm going to walk. Let's do
Yeah,
it.
yeah,
It's like, I think the
dude.
same thing happens in dentistry, but we don't think about it as much.
Yeah, because we think, well, we cop it, but the patients don't think about it. They're sort of
Yeah.
saying, like I know, I'm not supposed to be eating on it, but if I haven't, no, dude, you're not supposed to be eating on it. You're not supposed to have anything on there. Like
Yeah.
what part of you're not supposed to be aren't you getting?
Right.
But they just think things aren't as serious in the mouth
Yeah,
until
it's true.
everything fails and they paid
Well,
a ton of money, and then
it's
it's
like
like, oh, but it's
whenever,
your problem.
yeah, whenever we have patients that come in and they broke a tooth, right? Rarely are they like, oh, I was eating a hard candy, or I was eating,
Oh,
it's always like,
I was
I don't
eating
know what it
soft piece
was.
of toast. It was a
Soft
piece of bread.
bread, or it was a
It
tomato,
was a marshmallow.
Yeah, and like going, it wasn't
Oh,
the tomato that broke the tooth. It was
that
the
was the straw.
gobstoppers before and
Yeah,
the freaking rock candy that you ate an hour
yeah,
before,
yeah, yeah,
Yeah.
yeah.
That's
It's
a good point. You
classic.
said how patients don't think that things in the mouth are as important, right?
Yeah,
I always give this example. Like if you touched your hand and it bled, you'd probably go to the doctor, right?
you freak
Like,
out.
what the hell is wrong with me? But people brush their teeth, it bleeds all the time, and they go,
Yeah, it's
how
been
long
like
has this
that for
been going
years.
on? Yeah, I
Years.
think 10 years, something like that. And
Yeah,
it's so
it
true.
stops and then it starts.
So it's fine. Or like the same
Sometimes I
thing they
get
say,
pus out of one of
yeah,
my
I push
molars. I
on
get,
it.
yeah, push in it, and then it's good.
Right. It's good for a few months. It comes back. It's fine. You're
No
like,
pain, no
yeah,
pain,
no pain. It's
no
fine.
pain.
Yeah. I think that goes back to this whole like separation of medicine and dentistry, right? Whenever it's separated, a lot of bad things happen, and
Well,
hopefully we can
yeah.
bring all that back.
Well, I think
With
this current climate is bringing it back. I mean, it's horrible that this is what it's taken, but I
yeah,
definitely think this current climate has brought medicine, dentistry back all together because,
yeah,
now people are realizing, susceptibility to disease, it's in the mouth, it's through hands, and they're seeing it as uh, one
holistic,
united front,
yeah,
one risk factor.
right,
And people now, all of a sudden, are looking at it from all aspects. Um, it's
yep,
just a shame it took something like this to sort of, wake up people or make them think a little bit differently. It's a bit
yep.
sad, but, it is what it is. But hopefully out of all this that's going on, hygiene and sort of self-preservation is going to come out of it. People are going to think differently. And I guess we'll probably start with the mouth, I'm hoping.
Yeah. Hey, we've got to stop and start again because I don't think we're done, but Instagram will stop us. So I'm gonna stop this and start it
Yeah, sure.
again. And so let's join
Sure.
back up. Okay.
Okay.
There you are.
Yeah, I'm back.
There you are. Can you guys hear me? I saw someone
Yeah.
said no sound. Yeah.
Yeah, no, it was for a sec, but I can hear you now. Can you hear
There we
me?
go. Yeah.
All good.
Yeah.
All right.
Yeah. Yeah. So we're talking about complications. Hey, my dad's on. Hi, Dad.
Hi, Dad.
My dad's a dentist also. My brother's a dentist. Oh, good. Brian can hear us again. Um, Ethics, I think, is a good thing to talk about. It's something that I think, Miguel talks about, but minimally invasiveness, like we talked about, this is something I guess that has changed in me. Not that I've become more ethical, but I've become more about saving teeth.
Yeah.
I think before, I came out of my residency, we're talking about implants and all this stuff, and I love just doing implants, right? And now, it came from a lot of discussions in our WhatsApp group is, saving teeth and what happens 10 years later and how the maxilla grows down and back. And, Joseph Kahn shows good cases like this where he does a beautiful case, and then 20 years later, the patient comes back, the gingival margin has gone like this, and it looks like the implant was placed so far buccal. And I think early in my career, I judged a lot of other dentists very early. And I said, oh my gosh, they placed this implant so far buccal.
Yeah,
and then,
they don't know what they're doing.
Yeah, they don't know what they're doing. I'm going to fix this, right?
Yeah.
And then I would, find out the history, and it's like, oh, it was placed 25 years ago. And I'm like, oh, it was probably placed in the right position then. It's just the maxilla grew back. And I think this is something that we still don't have all the answers on, but we know, I think it was 2 or 3 years ago at the European Academy of Osseointegration, they were talking about how maxillary growth happens in 40s and 50s even.
In females. So quick question, Carl.
Yeah.
What's the minimum age you would do an anterior implant if a beautiful LA actress walked into your studio?
Yeah. So this has changed for me.
Yeah, that's right. For me
This has changed for me. For me. Now
5 years ago, 5 years ago, what would you
5 years ago, I would have done 18, 19.
Yep. Oh, really? Okay. All right.
And now it's 30.
3 years ago.
And now it's 30,
Yeah.
I really try to do anything I can to, especially if it's anterior.
30s. Late 30s for females.
Really, late 30s. Oh,
yeah,
nice.
Late 30s. Yeah. Just and there's a lot. I mean, they just need to understand it. And if they want an implant, then they got to sign a ton of documentation that they accept that.
Well, the hard thing for me are centrals.
Yeah, centrals and laterals are.
Centrals, but I'm thinking centrals from a guiding point of view. So if we're gonna do bonded Maryland bridges, which have very long success rates.
Yeah.
Anterior guidance, we have got to make sure that we can get that maybe on the contralateral central. And so that's I think where.
And how do you get that? And how do you get that?
With ortho.
Hey,
there you go. We're back. Yeah.
So they're things that you seriously, it all comes back to orthodontics, understanding occlusion and setting yourself up, and all the more importance, and if that's not an issue, you can do tabletops and open up that area. I've done a lot of cases where the occlusion it's okay, but it'd be nice if I just had a little bit more. And then you do prepless tabletops exactly on top. All of a sudden, you've got so much room on the underside to be able to put that bonded Maryland, that retainer. And just by simple overlays, very conservative on top of what you've got, if you're not going to do any orthodontics. Because sometimes you can have a beautiful arch, but it's just a little bit deep, extrusion mechanics and so forth. You could do a fair bit of work. But another nice, simple solution I find is just overlays, just simple overlays. I know you're putting something on a tooth that I don't have an issue with that because I'm not prepping the teeth. They're hardly prepped. They're literally, go back to the tire analogy. I'm just putting some thicker tires on there. And then all of a sudden you get this, you've got, this anterior segment, you've got enough room for a retainer. You can manipulate it a little bit more, and it makes a huge difference.
Yeah, it brings back that whole idea what we were talking about at the beginning. So someone was asking 30 years for women only. What's your difference between men and women there?
Because I think, I know from some of the literature that's come out, women continue to show changes way after men. So men tend to stop maxillary growth and facial sort of changes.
So for men, what's your minimum kind of age?
Look, I'm comfortable with a man 30, 31, just around that time. I'm comfortable with that. Yeah. But females, I tend to do late 30s, especially now, Yeah. I've seen one of my implants from 26 years ago. Oh, I cringed.
So what happened? It looked too buccal and it looked too apical, right?
It was, But buckled slightly, but way
Yeah.
high up. Yeah, it's tough, you know.
So
So,
I had a
um,
case that I placed in a girl who think was, I think she was 30. I placed it,
yeah,
central incisor. Actually, I did this with Sasha, so I restored it. Sasha did the implant actually,
yeah,
and we finished perfect. I showed it in all these lectures, and we saw her back at 3 years. Only at 3 years, it was already a millimeter off.
yeah. So that's crazy. Like that scares the hell out of me.
Yeah,
You know, that
and
terrifies the hell out of me.
I wonder. I hope that with you and I are both into AI. I hope that AI will help with big data on this because like this specific patient was of Asian descent, and I wonder if there's any difference. You know, it would be nice to really have an answer to this, whether it's through genetics or whether it's from big data, whatever it is that will give
Yeah,
us
yeah,
the
definitely.
answer there.
That's yeah. Again, like now we talk about the changes, but is it genetics? Is it predisposing factors? Is it a cultural background? Is it more prevalent in certain demographics? It's like we don't know. All we're seeing now
Yeah,
is I've seen it in females. I've seen it continue to grow. So we're just putting this blanket
blanket
uh,
statement, right?
blanket statement. It could be
Yeah,
certain demographics don't have it at all. Certain genetics don't even affect them. So, but we don't know that at this stage. I think it's probably better to assume it will happen
yeah.
rather than take that risk. But again, AI, and if we can track that and start to document and start to sort of trace that, then we might have a chance. But at this stage, I think I would tread on the
Error on
cautious
the side
side.
of caution. Yeah,
Caution. And those treatments, like I said, those fixed unilateral and done beautifully with a soft tissue, and where you and our colleague Tony Rotondo is a master
oh
of this
yeah.
stuff. He does some
They're
beautiful
amazing.
and all these beautiful techniques.
Yeah,
Oh man, some of these bonded bridges look amazing, and
yeah.
they're conservative. You're not prepping the teeth at all.
Nope.
So again, create the space, maybe
Yeah,
orthodontically, or just do those tabletops, and all
yeah.
of a sudden you change the dynamics of everything. So it's not. I don't think it's an obsolete treatment. I think some of these aesthetic cases are better than the best implant you'll ever do. So this
It's
is
true.
something we have to educate patients on. So it's not an inferior option. It's a different option. And then
Yeah.
once you tell them that, the risk factors and what's the worst thing that can happen, it can break and I can just do another one.
Do
And I'm
another
not
one.
even
Yeah.
cutting your teeth. Why wouldn't
Right.
they?
Yeah.
So they just need to understand that it's not a temporary solution, but this is the reason. So I don't have
Yeah.
to drill your implant out, remove half your jaw. You'll go without a tooth for maybe a year,
Right.
so I can regrow that same implant
Yeah.
site. So once you tell them that, they're pretty cool.
So there was a question from Christos. Should the general dentist perform ortho? I'm asking because as an implantologist, I totally respect the specialty and I don't agree with the approach that a company performs everything. Yeah, I think you're right in the sense that should one person do everything? No, but I
No,
think
of
that
course
you
not.
can do multiple specialties and do it well. And even I think like how you're doing it to where you do implants, right? You do the prosthetic, you do the ortho, but you draw a line at some point, right? Like you don't do the zygomas or,
No, no,
certain
no. I
people
don't
say,
do
I don't do this type
zygomas.
of
All
grafting or
my
I don't do this. Yeah.
endodontics
Yeah.
is done by an endodontist. Certain, all the perio I do. I mean, I love to do soft tissue stuff, grafting like
Yeah.
yourself. We love that stuff. But no, but what you need to do is get an understanding. If you're going to be delving in that sort of treatment, you have to study it so that when you delegate it, you actually are aware of what's available. Because you could be working with a specialist, but
Yeah.
the specialist doesn't know the restorative aspect as
It's
much,
so true. Yeah.
or he doesn't even realize these things can be done. Don't assume just because it's an orthodontic specialist, they know all the available treatment
Yeah.
modalities. There's some
And I think this
amazing
is,
guys out there,
I think this
but
is
there's
a
also
statement
some
that
guys
can be
that don't
applied
yet.
to every
Everything.
specialist, right?
Yeah.
To every specialist. I think one of the good things about general dentists or restorative doctors, prosthodontists, whatever, doing any type of specialty work is that they think about the end goal, right? Because we have to do it, right? It's a selfish thing.
Yeah.
we don't want to get ourselves in a place. So it's like when, you know, I place my own implants, I restore my own implants. So when I place an implant, I know that I have to restore it. So I'm communicating with myself. If I place the implant in the wrong position, I'm the one that has to be screwed at the end of it.
Yeah.
But
that's exactly
you know,
right.
I have specialists that I can work with that do get that and that do understand it. But there's also specialists out there that don't get it. And so it's like what you said, just because you have a specialist, don't assume that he or she has the kind of multidisciplinary mind.
No,
but when you can find one, they are worth a lot.
They're like gold, basically. And you have to find them. And the only way you can find them is if you understand the process. You have to read all those, read all of Cohen's books, read all of those, global diagnosis. You have to know that stuff inside out. I'm not asking you to do it, but you need to know, you need to be able to call that orthodontist and say, hey, I need you to move this. I need you to do this case, but I want you to equalize the gingival margins. I know the teeth are going to be all different sizes at the end. Don't worry about that. I'm going to do the veneers, but I need you to equalize the gingival margin. Now, if you've got an orthodontist, and I've seen this, that doesn't understand gingival margins and aesthetics, I've seen them finish cases where they finish the incisal edges. Then you look up and think, oh my God, the central's down. And it's a high smile case. Like, that might seem very basic to you and I, but there's certain specialties that they are so specialized, they don't see anything else. So what I'm saying is, as a dentist, you are the coordinator. You are the coordinator. Now, whether you have an interest in that area, because like you and I, we love soft tissue stuff, we love implants. That's our thing. But you still need to be proficient and understand all of that. So if you've got your surgeon, and I've seen a lot of surgeons place implants and not provide any restorative space. Implants are beautiful.
For sure.
They're amazing. They're integrated. And then they come and scratch their head. The patient, I've seen the patient and they said, okay, I said, there's no room to put teeth. And if I do, they're going to have phonetic issues. What's the solution? You're going to have to remove the implants. Are you kidding me? You know, these are so you need to be able to coordinate all those and then put your core team together. Get your ace orthodontist that I want you to move this, and that, and it's done. And timing's right. Not to procline too much because I'm going to be placing veneer. Or I'm not going to be placing any veneer, so I want you to finish in a perfect position. Like all these factors. But you need to coordinate it. You just can't assume that they know this.
Yeah. Well, I've seen this. I guess there's something very good about being super specialized, right? And the good thing is that you do the same thing every day, so you must be good at that. Now, the bad thing about that is that you don't know other parts of dentistry, right? So I've had some colleagues that went to, for example, oral surgery program, and they never teach them about keratinized tissue around implants. And so their whole residency, they're punching tissue, punching.
Don't make me cry.
I know. Cry. And then they've contacted me because they're friends and said, hey, I'm having all these problems. What's the deal? Is it the implant company? Is it my loading it too early? And, I'd get their photos and say, are you punching every time? And they're like, yeah, that's how they taught me. They taught me just to punch every time. And so we have to just have enough know-how of every aspect of dentistry to delegate where we need to delegate and communicate where we need to communicate. Christian always says that the super GP, what the super GP should be best at is diagnosing and treatment planning, right? They don't have to be the best at ortho, at implants, at extractions, at restorative, whatever, they have to be the one who can treatment plan everything, get the right team involved, whoever it is, whether it's one person or 5 people, and then have the end in mind and work backwards.
And understand all the available procedures. That's the key.
Yes,
as a general dentist, you have to know what's out there. You have to know that what's the difference between a free gingival graft? What's the difference between a connective tissue graft? Timing. You might not have to master these, but you need to know about them, and you need to know someone that can do them, because otherwise you can't do these cases. That's the issue. So whether you feel comfortable, if you and I have interest in certain areas, so we will study, do further studies, and so that we can do that. It doesn't necessarily have to be the case, but at the end of the day, even if we don't do that, we have to understand it. We have to understand ortho. We have to have all those disciplines if you're going to delegate someone. So I understand your one of your viewers' comments that if you don't want to do it, that's fine, but you need to totally know how to do it, and you need to get the right person involved. Otherwise, just to pick up, you know, a specialist and say, yep, I'm working with a specialist, it has to be someone that understands it. That's a key. You know, there's that assumption that all specialists understand all procedures and can integrate into your, you know, treatment planning. It's definitely not the case.
Yeah, I think the best teams in the world that I can think of, and whether these teams are multiple people or single people, it's the communication and it's the process of knowing the surgical side and the restorative side and the ortho side and everything all together. You know, like you look at Eric Van Doren's team, right, in Belgium. And, you know, he's got the prosthetics, he's got the lab technicians, he's got ortho, he's got, you know, all these people. You look at like Iñaki Gambarina and Marcus Blatz, you know, you've got, that could be done by one person or it can be done by a team. But having that whole interdisciplinary mind, you know, or you think of Mitrani and his group in Mexico.
All of that. It's like when we do our full arch cases. Say I'm doing a zygoma case, so I'm there, my zygoma surgeon's there, and my technician is there at the surgery. We're all in there. He's gowned up. Like, that's the only way that sort of stuff happens. You know, generally, you would find, you know, the surgeon, you know, some people think these cases happen, well, my surgeon's going to do the implants, patient's going to come to me, I'm going to take an impression. Those cases, everybody has to be in the room. Like everybody has to be. It doesn't work otherwise.
Yeah, well, I place most of my own implants, but there's certain cases that I don't place, whether they're really difficult or I just don't want to deal with it or whatever. And we just had a case that I referred to one of my colleagues, Human Zerenkelk, who's like a zygoma master. And we didn't end up needing zygomas for this case, but I was up, and again, me as a restorative doctor, I was in the room while he was placing the implants, not because I was, you know, I was going to restore it that day, but also because he was asking me, hey, Kyle, is this okay? Is this deep enough? You know, do you have enough space? Where's this?
Or you know, depending on what sort of protocol to use, you've got your digital stent and you say, okay, you know, I'm going to have the access coming out through the, you know, through the, between the premolar and the molar. Are you okay with that? Is that too lingual? Whereas like, it doesn't happen. It can't happen without you being there. So that's exactly what happens with us. I'm there, I'm assisting, and then I've got my, you know, technician basically confirming everything where we're going to finish. So
it's a really good point you bring up with technician, because, you know, we got our technician Paulo Batistella from Brazil almost a year ago, and what Paulo loved, because he was always his own lab, right? So he never got to be in the
clinical environment
as much. And so he was saying when he first came with us, he got so much better because he was seeing immediate feedback. You know, he was trying it in the mouth, making adjustments, seeing actually how it finished, not just on a photo, but, you know, we call him in every time we place something. If it's good, we cement it or we lute it or we screw it in or whatever it is. And then we call it in and he takes a look. And every time he can see that physically is like feedback. It's like in an AI, you know, algorithm, getting that feedback, you automatically get better.
He's seeing it. And it's his version of machine learning.
Exactly. That was how I think Christian got so good, was because he was interacting with the patients, trying his restorations in, seeing
he was there. I mean, that's where he realized, you know, facially driven dentistry. So he basically, you know, brought across, you know, he was doing beautiful cases because he was right there. And he was seeing technicians were just, you know, working on models. But when he was seeing the faces, he was sort of, he relayed, he was able to, he was the first guy to bring that crossover where he sort of said, you can't do prosthetics, you can't be a technician and not, you know, bring the face across into your restoring protocol. So hence, you know, how do I do this? How do I bring this across? when the patient's gone and I'm out of that clinical environment, you know, what do I need to do so that I have the face in front of me? I mean, his stuff was, you saw his older videos. He had, you know, printed face photos, started drawing lines on them, because he realized you need to bring that in. Just like when we work, we have to work on the patient. You know, we have to see what we're doing. So how could you ask a technician not to have some sort of level of connection to the patient? You're going to give them a tooth. So again, especially with these complex cases, you throw them in there and you just see them. It's exactly what happens with my technician. His cases, you look at his cases 6-7 years ago for the full arch, you look at his cases now, I can categorically say every case he does gets better and better and better and better and better. You know, just things just happen, like even minor things. You know, when you do your indexing and your vertical and you just see, you know, I say I want this, this, and that, and it happens because he's there. You know, it's crazy.
And that brings up the same point we were saying about specialists and general dentists. Everybody has to have basic knowledge of each subspecialty. It's the same thing for technicians, and oftentimes we forget about the technicians as like a subspecialty of dentistry, right? So like when I brought Paolo to our Zero Bone Loss Concepts course. And so he got to see me and Thomas Linkevicius discuss how to design prosthetics. And so for him now, he understands the biology behind prosthetic design. And that is such a, you know, he was just showing me a case right before that we have to actually send out to a patient in another state. And I was asking him, you know, is that under the gingiva, is that polished zirconia? He said, yes, absolutely. Like he just knows not to put glaze there anymore. And, you know, when you have these technicians and any subspecialty, let's say, that understand the different parts of it, then everybody rises, right?
But technicians are great. You show them once, you show them twice, they get it. You know, like, it's funny you said the polished zirconia thing, because I'm pushing that big time now. And now, you know, now he's telling me, guys, check out the zirconia up. Like, these are things, and you just tell them. But again, unless you don't know and you don't transfer that information, whether it's your technician, whether it's your specialist, whether it's your existing auxiliary team, if you don't do that, things just don't happen automatically. And it's like AI. It's a constant update. You know, we keep hearing stuff, we keep having little modifications, you know, little techniques, but they have to be adapted, they have to be implemented. So it's tough. Dentistry's tough, you know. You can't sleep. You know, you can't have you've got to be on your you know, on your game every day. You've always got to be on, you know. Always got to be on. And if you want to practice at that level, it's your brain's always got to be open and on, and you've got to be always interacting with colleagues. Like, stuff like this is incredible. You know, we've got a common group. How much do we learn out of our, you know, interactions? It's incredible. Like, this is I learned more out of our group than I did at university. You know, that's right. I know I don't like to say that, but some of the stuff we pick up, and then it guides you in the direction. You can do your own research. It's incredible.
Yeah, it's so true. And you know, there's good and bad about social media. And one of the great things, you know, one of the bad things that I think Christos was talking about is you have like Instagram universities, right, where people learn and then they go and do it without necessarily doing the proper research or training or whatever. But the good aspect that comes out about that is people get exposed to things very quickly, right? So I can't imagine doing dentistry 20 years ago when, you know, the Corey technique is developed somewhere and it doesn't get to your city for 10 years.
5 years, 10 years.
And now we can treat patients better, minimally invasive, faster, cheaper, more predictable, because we do have this spread of knowledge fast. But we just have to be careful about how we implement that and make sure that we're doing it to our own skills, right?
Yeah, because there's also the complete, you know, there's the complete disadvantage of having too much knowledge too quickly. It doesn't give you that pregnant pause, so that, okay, all right, you know, where does this fit? You know, how much data is there behind this? You know, is it anecdotal? Is it just hype? Is it marketing? So before you jump in. So you sort of, but this is where a community like ours, where, you know, you can bounce these ideas around and
Yeah.
ask and see. But
Yeah.
yeah, like I said, it's a good time to be practicing, but it's also a very scary time to be practicing. So
Yeah, it's true. So I think we've talked a lot. We've talked about some really good stuff. I love that we got
good.
into ethics, and ethics really in restorative and ortho and
Yeah,
multidisciplinary treatment and full arch. I mean, I think that's a really good conversation.
I think we did all right.
I think we did okay. Thanks everybody for your questions, Christos especially. Thanks for asking so many questions. That really helps us.
Yeah, great questions.
Any kind of last words or final words or advice? I always ask for advice for younger doctors because I have a lot of followers that are, you know, maybe just out of school, first 5 years.
Uh, I always, you know, one thing for all these young dentists, a bit of advice: be patient. Dentistry is an amazing profession. It truly is an amazing profession. In hindsight, there's nothing I would possibly do if I had my time around again. I've been, like I said, been practicing for 30 years. It's such a beautiful profession. It's such a deep profession. There's a lot of things that can keep you occupied and keep you interested and make you want to get up and go to work and work hard every day. That you just need to be patient. It doesn't happen overnight. There's a lot of great colleagues out there that you can reach out to. If you can harvest the patience, you will really enjoy your profession. And always speak to your colleagues. Carl's a brilliant advocate of, you know, staying healthy mentally. It is a really tough clinical environment. It's tough, you know, in all aspects. So don't ever fall into that pit. There's, you know, you've got lots of people out there you can reach out to, and don't feel like you're the only one. We've all gone through it for many reasons. So, and that's one thing you should never let sort of happen. So just, you know, put your hand up, and you will find there'll be 10 hands that will grab it. So
it's really great advice. I think one thing that social media has done is that, well, it's done, we've talked about bad things, but one of the great things is it's brought together our international dental community, right? And dentists love to talk about dentistry. It's like when we were chatting last night and, you know, Fadi, you said, so what do you want to talk about? And I said, well, let's talk about this, this, and this, this. And you said, we'll talk forever. And it's like, it's totally true.
Exactly right.
Yeah. You get two dentists together and we'll talk forever. So, you know, having, we love what we do. We're so passionate about what we do that we need to know that we have each other to reach out to, right? Yeah. And whether it's someone in your community or it's someone around the world, we have advocates for each other and we have help. And we, you know, if you need help with anything, mentally, clinically, whatever, you know, reach out to me or Fadi. We're happy to help. So, yeah.
And
well, good.
And nobody understands dentists, Carl, better than dentists.
That's true. I talk about this all the time, is that sometimes you feel like you can't go to your spouse, you can't go to your siblings, you can't go to your parents if they haven't kind of been through the trenches, right? They may not understand it. So yeah, reach out to another dentist. But thanks everybody for coming, and Fadi,
thank you, Carl.
You know, all the best to you and your family and your son.
Thank you.
And hope to see you in person again soon.
And I'll see you hopefully at the end of the year once all this blows over.
Sounds good.
All
right, guys.
Have
Thanks
a good
for coming.
day.
See ya.
Take
Bye.
care.